Gossip.
This is Polyp Gossip, the place for physicians and patients to catch up on what's hot and what's not in CRS with NP or nasal polyp syndrome.
This podcast is developed by Sanofi Regeneron and also elaborated in close collaboration with EUFOREA. Welcome again to Polyp Gossip, a wonderful initiative where we discuss items around CRSwNP that has never been discussed before. This is an initiative taken by Sanofi Regeneron with support of EUFOREA, and I'm thrilled that today we will be talking about the Global Awareness Day of CRSwNP, or the Awareness Day of Nasal Polyp Syndrome. You know that on an annual basis, a CRSwNP Awareness Day is being organized by EUFOREA, and today, during this podcast, we will mainly discuss the patient journey. There are so many issues about the patient journey that are still not discussed properly amongst the rhinology community nor amongst the patient community, and therefore I'm terribly excited that today we have 4 panelists that are willing to discuss issues related to the patient journey that can all help us to treat patients better and also help patients better to achieve a higher level of quality of life on the one hand and also higher likelihood of control and remission on the other hand. And let me now introduce the 4 panelists of today. First of all, we are very privileged to have 2 patients with a long disease journey with us. The first one is Daisy from Belgium, and the second one is Troels from Denmark. So welcome and thanks for joining us during this podcast, Polyp Gossip. And we also have 2 experts. One is a colleague rhinology from Sweden, my dear colleague Cecilia Ahlström Emanuelsson. Thank you, Cecilia, for joining us, as well as Dr. Xander Bertels, head of the advocacy team of the European Forum for Research and Education in Allergy and Asthma, which is the EUFOREA team. And Xander, thanks for joining us and also sharing your insights on advocacy. I would like to start off by hearing the experience of Daisy on the first symptoms related to CRSwNP, how impactful they were, and how she struggled in finding the right solutions for these symptoms. So Daisy, the floor is yours, and share your first symptoms in relation to CRS with nasal polyps, please.
Yeah, for me it wasn't very clear at the first moment. For me, it's a story of more than 15 years of journey, searching for treatments. The first symptoms start as I was a child. I had a lot of colds, a lot of ear infections. I visited a few specialists, but they couldn't help me. Afterwards, I lost my taste and my smell. And finally, in 2011, I came with a specialist and he helped me. And from then on, I've got a lot of treatments to get better.
It's truly impressive, and thanks for sharing that long disease journey. It's truly impressive to hear that it took you so long to find somebody who could not only make the correct diagnosis, but also provide you with treatment that had an impact on your quality of life. Is that correct?
Yes, indeed. And quality of life is very important for me. Yeah, for everyone, I guess.
I would like to hear and go now to Troels and hear whether or not his first symptoms also took many years before finding the right physician who could not only diagnose but also define a therapeutic strategy. So Troels, can you share your first symptoms and how you experienced the first steps in your disease journey?
I started beginning to get a lot of allergy. In the beginning it was just in the summer, and then it was also in the winter, and then it started to, if you eat something, if you eat candy or go to like sushi restaurant, then it will give me problems. And then I began to get a lot of asthma issues, but it was still the first 3 years when the problem was there, where I go to like a normal doctor and then go to the first specialist, and it was after 10 years, one day, then I just met the right people that fixed everything.
This is really striking. If somebody experiences vision loss, for instance, this is immediately tested, this is immediately referred for, and patients find the correct diagnosis within a reasonable and short time frame. But for patients with CRSwNP, this does not seem to be the case. And I address now this question to my colleague Cecilia Ahlström. What do you think is the reason why patients go to such a long disease journey before having their first and proper diagnosis made? Because from my opinion, a first diagnosis isn't that complicated. So what's your impression, Cecilia?
I think it's quite often that you just think it is a normal cold or something, and it will go help from myself. Time will heal it. So we don't look into the nose properly and see what's actually in the nose. And that's, I think, is the biggest problem. So we bagatelize the things and think it will go over.
Most of your patients that you see, Cecilia, how long is their disease journey going on? Is it already for many years, or is it depending on the healthcare system where you work, whether or not you see patients that are just coming to see you for a first diagnosis, or do you see patients that have been suffering for 10, 15 years and finally find out they have CRSwNP?
Both, I would say. I'm working at the specialist hospital, and we get quite a lot of people referred, and you have to have a referment to come to us. But I think that quite a lot of people have a long journey to have this diagnosis, at least 5 years.
I would like to know from Dr. Xander Bertels, who coordinates and works on a daily basis with 85 patients that are part of the Patient Advisory Board of EUFOREA, whether or not these patients also experience this long disease journey on the one hand, and what they kind of suggest as a solution to overcome this long term before they have a proper diagnosis made.
Well, absolutely. I mean, the stories just heard, that's exactly in line with what the patients from our advisory boards tell us. It's a long journey. It's a lot of trial and error, which is not addressed in the sort of proper way. There is a lot of self-management where patients are a little bit lost in the right guidance, and indeed the referral to a specialist that confirms the diagnosis is prolonged, which also makes an impact because, of course, the disease can worsen over time. And the moment they then are referred, they already have some severe symptoms. And the thing is, I agree with Cecilia that indeed the distinction between acute and chronic is key here. I think there's too much that the symptoms are considered acute and are treated as being acute, while it's actually a chronic disease that is not fully acknowledged and properly treated. And in terms of how we address this, it's of course a very difficult question because it can go wrong on different stages. So there are many things that need to improve, but one of the things is of course the name. CRSwNP is a very difficult name. It's most patients that our advisory board tell us that it's unpronounceable, and it's not like asthma or diabetes that are more generally known in the general public. So it starts, of course, with awareness that this can be a disease.
Very nice. What I also hear from my own patients is that indeed they are referred from the one to the other physician, sometimes a pulmonologist if they have some shortness of breath or asthma symptoms, and then back to the rhinologist, and then to the immunologist or allergologist. So quite often there is not that smooth collaboration or multidisciplinarity in the approach. And I would like to hear from you, Cecilia, how you approach this kind of patients with CRSwNP and comorbid asthma, and how you deal with those in your clinic.
We are quite privileged here in my clinic because I'm working at the allergy department sometimes, and we're working next doors to a pulmonologist. So if we have patients with chronic rhinosinusitis and they have more lung problems, I just walk over the corridor, and if I have some problem, I talk to my colleague. And the opposite, when he has asthma patients and they're complaining about the nose, he just walk over the corridor and I look into the nose. So I'm very privileged in that way. And in that way also we have been more known about the problems with the nose. I mean, the pulmonologist, he's now know that the nose could be involved when they have asthma. And I think that's the biggest point. They don't just look into the nose and say, okay, it looks okay or something. And they don't just send a referment and say there's a big polyps and we're just looking at the inferior turbinate or something like that. So I think in our department it works very well in that way.
Now I would like to hear from Daisy whether or not she experienced in her own disease journey some obstacles in being referred or in consulting a pulmonologist and then an ENT specialist and then an allergologist again, and not always having a uniform approach in trying to optimize care in the best possible way. So Daisy, what has been your experience in Belgium in the healthcare system at one of the university centers? Was it a smooth and a positive experience, or did you experience some frustrations?
Yeah, I had a lot of frustrations at first because, the symptoms started when I was a child, and I visited a few specialists, but they couldn't help me, so I was always disappointed. And then I had a positive experience because there was a specialist that started with a CT scan, and we discussed the results. And the results were, in fact, not good because there had to be surgery for my nose. But I was glad I had the first time a diagnosis, and I knew what was going on from that point. My journey was still difficult because I had to do a lot of treatments afterwards, but I was glad I knew, there was a diagnosis and
having a diagnosis and also the associated information about what to do, how to avoid triggers, how to prevent exacerbations can indeed be very reassuring and contribute to your health, well-being. I fully agree with you. I would like to hear from Troels what has been his experience in this journey where sometimes different specialists are not always talking to each other or not always collaborating in order to optimize care and define the best possible strategy. So Troels, could you share some of your experiences within the Danish healthcare system?
I think that you get the right point. The biggest problem is that every specialist are so specialized that he cannot talk with other specialists. So if you go to the nose specialist, he will say, this is a problem. And then you also have asthma. Then you go to the next place where they only look for asthma and only concentrate and look at how you provide when you make a blow test or something. And then after that, then you can go back to the first guy and he says, oh, now I cannot do anymore. So then you find a new specialist. So I have been giving up a lot of times in the systems. And one day you say, thank you. Then you take the surgery. And for me, it didn't help at all. It was it was a very bad surgery. It took very long to come over after that, and it didn't help at all. It actually only made the things worse. So I think the biggest problem is that they don't speak together or planning things.
No, you nicely highlight the weakness of healthcare systems, and this goes back indeed to also medical school and the subdisciplines that deal with either the lower respiratory tract, the upper respiratory tract, the immune system or the allergic component of disease. So that's exactly the consequence of this kind of arbitrary split up in specialties that you highlight here and where you have kind of been the victim of. How you feel about smell testing and whether or not smell testing was neglected according to your opinion or not, because this is often something we hear from patients, also patients in the US, for instance, when they present to their physician with anosmia, which is total smell loss. Most of those patients with total smell loss never ever receive a smell test, which is very striking to me, which is not optimal, I think, but I would like to hear your opinion.
I was surprised from my taste and smell test because the situation was I felt once sick after eating something that was overdue, but I didn't. I didn't smell it and I didn't taste it well, so I ate it, and afterwards I felt sick. There were a few of these situations in a few weeks, and afterwards, you know that there's something wrong, but you don't know what. So I made an appointment with my specialist, and then we did a test. There was, I think, 1 or 2 items that I had correct from the test, and all the other ones were wrong. So I was really surprised from the results. And then the nurse they told me, you have to be careful because you will eating something that's not good for you, and it's dangerous. For cooking, for eating things.
This is really striking. So if I understand you well, you were not really aware about the degree of smell loss you experienced, right?
No, for me that was the first time, and I didn't know what was wrong.
That's interesting. How was it in your case, Troels? Did you experience smell loss, and how this was dealt with? Was it properly diagnosed? Did you undergo a smell testing or not? Can you disclose that information, please?
I discovered that my smell was totally gone. And then I think I went to the specialist about 3 months later, and they offered me this smell test. And it was, I couldn't smell anything. So the last one is always the one that tastes of old fish. And the lady that was, giving me the smell test was very pregnant. So it was so funny because I couldn't smell it, and then she said, maybe it's old. Then she just puked in the office. So it was okay.
That's a nice anecdote. So Cecilia, I think you agree with me that more and more colleagues of ours are performing smell testing in daily practice. Is that also the case in Sweden? Or does it still remain the privilege of academic centers where smell testing is being performed?
If you mean of the whole of Sweden, you can do smell testing in a lot of parts of Sweden, but I don't think you do it on all small hospital or small specialist centers. Then they have to refer it to the centers where you can do smell test. But I think more and more we are getting aware of it, and I think more and more places do some. It's quite easy to have these sticks or something to do the smell test, and I think we are trying to get it out all over the whole country to do it. But I don't think that every patient who comes with that you suppose it could be polyps, or maybe you see polyps, chronic rhinitis with polyps in the nose. I'm not sure that everyone gets a smell test in that way, so you can confirm it, but you always ask the patient for it. But I don't think everybody does a smell test.
Just another question for you, Cecilia. Do you consider smell testing to be extremely challenging or extremely bothersome?
No.
Why do you then think that not many secondary care colleagues of ours don't perform it?
I think it could be a cost thing, because if you don't use it so much, it's cost quite a lot and they get old. And maybe you think it's, if you have a polyp patient, okay, they don't have smell. But maybe you don't test it. If you don't have so many of them, you think it's too expensive, I think.
No, I fully agree with you. I'm just teasing you a little bit because I'm really surprised that this kind of simple test still remains neglected in many areas in the world, as well as in many ENT practices, despite the fact that this test is very simple. I don't know how the patients of the Patient Advisory Board of EUFOREA think about this, and whether or not they have any kind of clue or any kind of suggestion how to improve practice in relation to smell testing.
In terms of the Patient Advisory Boards, well, yeah, it's an interesting, because we discussed that in one of the last advisory boards, specifically the topic of smell loss, because it's such a impactful sort of manifestation of the disease, of the inflammation of the nose and sinuses. And it has a real impact on the patient's lives, as we heard already a little bit. The fact that you cannot smell does not only mean that indeed you cannot smell food that is rotting or gas leaks or fire, but it also means that your experience when having everyday things like going on a restaurant with family and friends is severely affected, because indeed it has an impact on taste, and it appears also to have an impact on memories, on remembering certain experiences in life. So it has a much bigger psychosocial impact than most people realize. Even as a patient, you might sort of indeed normalize it a little bit as, oh, I'm having a cold, I'm having a very long cold. But it's actually a very, very important symptom that needs to be objectified by the physician. And I think indeed asking it is one, but also testing it's something that the patients indeed appreciate, because then you, of course, do the effort to see how much of smell loss you have, how severe it is. And I think that's one thing from the advocacy point of view. And I think making it more in practice means also indeed raising some awareness on that impact, because once the medical community in primary care especially know about this, patients know about this, then I think testing will follow more also in secondary care.
From the feedback of patients, and I will first address this question to Xander, from the feedback of patients, what do they suffer from most? Is it smell loss, headache, or nasal congestion?
Oh, it's a difficult one. It depends from patient to patient, of course, but other patients are severely affected by congestion. They cannot sleep. They are then very drowsy at their jobs. So then that sort of symptom is more. And it can often, there is some comorbidity with allergic rhinitis, where there is additional nasal congestion. So it's very individual, but I think, of course, all these symptoms are very bothersome. And they co-occur, which makes it even more difficult. And having that diagnosis is really key, and then having access to treatment options is of course also key. And that's something we have not discussed yet, but indeed it varies from country to country. And that's also the interesting thing about the advisory board, is that it's an international board of people. So we have the perspectives of patients in different countries, like we have a little bit here today. And that gives very interesting talks amongst us, and also to try to think of some things that are applicable for everyone, and that's good.
Thank you. Troels, what do you think if you hear this story about smell loss, headache, nasal congestion, and how bothersome each of these symptoms is? Could you share your experience with these symptoms, and which was for you the most bothersome?
I think you get everything except for one. When you cannot smell anything, then after a couple of years, you have very hard to be happy. You know, when you come home from work, then you know your wife have been making dinner. You open the door, you can already smell it. You know, this is good. Welcome home. You know, you don't even recognize it. It's the same if you go to like a public toilet. You know, there will always be in the end one toilet that is not used because this is a disgusting one. And you can just, whoa, that's a problem. So you actually begin not to feel what's good or bad. You're just in the middle all the time. And you can really feel how your sadness, you need to do some extra to smile, to feel, you know, like Christmas evening, when you look at the family, you know you're happy and everything is good. That's a very difficult one to find.
What you mention here reminds me of the former chair of the Patient Advisory Board of EUFOREA with smell loss, telling like living with smell loss or anosmia feels like living your life in black and white without having all the experiences of the colors in your daily life. So if I hear you, it's more or less the same experience. For me as a physician, it's very striking to hear all these stories. These stories have been going on for decades with patients suffering from smell loss. And never ever there were kind of major efforts in understanding smell loss and trying to find optimal care pathways apart from oral corticosteroids. I do believe that thanks to COVID pandemic with major smell loss and how people felt about smell loss on the one hand, and also thanks to novel treatment options that are available for patients with CRSwNP, we now have increased attention to the problem of smell loss and try to overcome this major symptom with novel treatment options and better diagnosis. So, Cecilia, would you agree with my statements, or do you have other opinions around this issue and how to deal with this issue in the future?
No, I think it's quite true. But I think it's quite important to notice that if you have asthma and you maybe the patient who is the physician who's treating asthma, if you ask something about the nose, because that is quite often something that you forget. And if you always, when you get an ulcer, you come to an ENT doctor, oh, that's why I can smell anymore. And you comment that way. The problem with the chest maybe is quite prominent, but if you ask something else and then you get the answer that they don't smell and they can't breathe with the nose, even if you treat it all, it's a little bit better.
So, if I hear you well, you would advocate for pulmonologists systematically asking for smell loss, nasal obstruction, and some other CRS-related questions in daily practice, right?
Absolutely. Don't forget the nose. It's the beginning of breathing.
Yeah. Well, this may be a bit of a sensitive topic, but of course we are here in a gossip context, which is a bit closed, so I can express what I think. But I've been frustrated for many years by seeing and observing pulmonologists neglecting CRS in many patients with asthma as well as in many patients with COPD. Is that also the same in Sweden, or is this just a personal observation of mine, having worked in different centers?
No, it's not a personal observation. But as I said before, I'm quite lucky because I work at such a department and we quite freely talk about it. But absolutely, I completely agree with you.
So, Xander, what can we do in order to improve the disease journey in the context of smell loss, also in those with comorbid asthma and comorbid COPD? Should we have a systematic screening for these kind of upper respiratory symptoms, or should we educate pulmonologists, or what would be your suggestion, also having heard the feedback of patients?
Well, there are a couple of things that we can do, and I think one of them is, of course, the pulmonologists. They're very used to working with the asthma control tool, which is a simple tool to check for control of asthma. It's something in the CRS field has been lacking for quite a long time. Fortunately, there has been some efforts lastly, and has been presented at some of the congresses in the last month. But of course, that's still in sort of the silos. We have the asthma control tool for pulmonologists. We have maybe a CRS control tool for ENT physicians and rhinologists. But I think what would be really great is that there is a sort of a unified respiratory control test where you can screen for uncontrolled respiratory disease in general. So then you might cover CRS, you might cover asthma, COPD, allergic rhinitis, and that could be something that is also very easy to implement in primary care. Because of course, in the GPs and pharmacists, it would be really good if we have a control tool that covers the respiratory tract. And that could be something that's also one of the suggestions within the Patient Advisory Board to develop that. And we've been actively doing that with the Patient Advisory Board. So now it's just a matter of making sure that this control test is really designed for clinical practice, because there are many research questionnaires, but they are very long and it's very difficult. And it's good that it's short and that it can lead to some actionable things both for the pulmonologist, for the allergologist, for the ENT specialist, and for the GP. So that would be the ideal solution, I think.
I see that time is running, and I would like to address a final question to all of you, and that is, where do you hope to stand in 5 or 10 years' time for patients suffering from CRSwNP? And what would be your dream for these patients? And maybe Daisy, I know this is a challenging question, but if you would be living in an ideal world, how would you design the care pathway, and how would you optimize care, irrespective of costs and irrespective of the boundaries that currently exist?
I hope for other patients that their journey will be much shorter than mine was. Because now I'm at a level that I can live my daily life like I wanted. And in the past, there was a time there has been a lot of difficult. I lived with a lot of difficulties, and it was hard for me to do what the activities that I wanted. So I hope that will change. And for the doctors and the specialists, I hope that there a better cooperation between the GPs and the specialists. You are working on it, I know, but sometimes the GPs are living on the wrong level of medication or treatment, and then the patient is still disappointed.
Well, that is exactly what we also hear from many patients of the Patient Advisory Board. So thanks for rephrasing that. And I think your dream for the future is really very valid and may become reality. So let's join forces and also make sure we can make it happen. Cecilia, what would be your prospection for the coming years, and how we can improve care pathways through advocacy or through any other healthcare system changes? What would be your prediction and hope for the future?
Depends on what are realistic or not. I mean, what I hope for is it could be a better collaboration all over, that we should work together, a smoother way from the general practitioner into a specialist and a specialist working together, more like a team, like a multidisciplinary team, more like for instance, for tumors, you always had multidisciplinary conference or something, a little bit more like working in a team. I think it's important. For treatment, if you ask for that, of course, everybody hope for one shot and then you're free from everything.
I would like to end by asking Troels what he thinks about the future and how he would advocate for more and better care through advocacy, or any other final reflection on what we have been discussing here on the disease journey. So the floor is yours, Troels.
I was hoping the team I ended up in Copenhagen, they have the best hospital. Then they had like a team when I went to. They were looking in the nose and say, oh, everything is together. And after a couple of hours, I leave. And 5 days later, all my problems were solved. And after 3 months, I stopped having this asthma problems. And after 4 or 5 months, then I have no allergy from everything. So I will just hope that the road to those teams will be shorter and will be easier to find, because I think this is the solution. But the problem is that now there is too many people to a very few teams. So it will the line will be too long for a long time before they can continue in a right tempo.
No, that's a very nice statement. I think we could go on for hours on the disease journey and how we think we can improve the disease journey by timely diagnosis, optimal care, the right treatment at the right moment, as well as advocacy initiatives that make the different stakeholders in the respiratory field more aware about the need for multidisciplinarity in the approach. But I'm afraid we have to end this podcast episode here because, we need to work. We need to help patients further. And it has been wonderful to discuss these disease journey issues with all of you. And I would really like to thank Daisy, also Troels, and my colleague Cecilia, and also Xander for having joined us in this discussion here in this very interesting and very relevant Polyp Gossip episode. And I hope we will meet each other quite soon when we have the next Polyp Gossip recording as well. Thank you so much for having joined us today, and let's keep in touch for the future. Polyp Gossip.
This was Polyp Gossip, sponsored by Sanofi Regeneron and developed in close collaboration with EUFOREA.